abdominal Doppler. So the objectives: have an understanding of Doppler physics, be able to use laboratory data to evaluate patients, a basic understanding of the tip's purpose and function, adequately be able to perform a liver Doppler ultrasound with or without tips using proper protocol and technique, and knowledge of renal artery anatomy, adequately be able to perform a renal artery ultrasound with proper technique and protocol, and be able to recognize pathology in the liver Doppler, tips, and renal artery studies. So I went over some physics stuff first with all the abdominal Doppler info. But the Doppler effect is a shift in the perceived frequency when either the source or the listener are moving in relation to one another. So, if you're standing in front of a moving source, so in front of the airplane, your perceived frequency is going to be higher than if you were standing behind it. And then the Doppler shift is the actual difference between the transmitted and the received frequencies of the ultrasound beam. Movement of the reflector in the direction of the transducer produces an increase in the reflected ultrasound frequency. Movement away is a decrease in the reflected frequency. The Doppler equation. So, the Doppler equation actually helps us be able to determine the velocity of the blood flowing. So the 2 in the equation at the beginning is actually because the sound beam goes out from the transducer and has to come back to it. And then the chart below. So the transmitted beam multiplied by the velocity of blood flow, and then the cosine theta, all divided by the speed of sound in tissue. So for us, one thing that we can control with the Doppler, figuring out the Doppler frequency, is our cosine theta. So at 0 degrees, the cosine equals 1. At 60 degrees, the cosine is 0.5. So the ultrasound machine is assuming we're receiving half of the information. So it's multiplying that information by 2 to actually give us the velocity. And then at 90 degrees, our cosine is 0. So if your angle is at 90 degrees, multiply it by 0, we get no information ever. And then Dopplers need to be attained at an angle of 60 degrees or less. If they're greater than 60 degrees, they become inaccurate. This was just an example I had found of angling the transducer beam. So the image on the left, the Doppler angle is at 89 degrees. The angle on the right is at 60 degrees, simply just by changing your angle of the beam. And all renal arteries look like that. Right. They do.
In books.
Yeah, exactly. So with grayscale imaging, our best images are actually when the transducer is perpendicular to the structure, and it's just because of the reflection that we're able to receive back. So if you're doing Doppler imaging, you may not be getting the best grayscale image. You kind of have to take it for what it's worth. So blood flow patterns. Normal circulation is normally going to be laminar flow. It can be disturbed in areas like the carotid valve where there's widening. It doesn't mean there's pathology, it's just a difference in the vessel diameter. And then turbulent flow has random components to it, and then we use our spectral Doppler, of course, to evaluate those waveforms. So your sample volume length can go into, it's a big part of evaluating those sample volumes. So if your gate should be approximately 1/3 to half of the vessel diameter and placed in the center of the vessel. If your gate is open too wide, you can cause spectral broadening. So it's actually just a filling in underneath this waveform. Other things that can cause that are a diseased vessel. So you could be artificially making it look diseased. If you're doing a Doppler on a tiny vessel, so you aren't able to decrease the sample length. that much, or actually if your gain is set too high as well. So liver Doppler. Covered liver functions and labs first. So the liver has multiple functions. The primary ones, metabolism. So with that, the liver stores carbohydrates. It converts it to glycogen and then stores it. If it is needed for energy, that process is reversed back to glucose. The liver manufactures many of the plasma proteins found in blood. It also aids in digestion with the production of bile. And then that's the breakdown of red blood cells. The liver stores iron and certain vitamins, and then also detoxifies drugs and poisons that enter the body. For the labs that we look at every day on our right upper quadrant patients, so these labs help us evaluate how the liver is performing under normal or disease conditions. So AST is an enzyme that's present in tissues that have a high rate of metabolic activity. It doesn't necessarily mean that there's liver disease, but it can be a clue that there may be. And it can be significantly elevated with acute hepatitis or cirrhosis. For ALT, it's actually more specific towards liver function. Slightly elevated with acute cirrhosis, hepatic metastases, and pancreatitis. Mild to moderate increase with obstructive jaundice, and moderate to high increased levels with hepatocellular disease and hepatitis. Alkaline phosphatase is produced by the liver, bone, and intestines, also the placenta, and it's a good indicator of intrahepatic and extrahepatic obstruction, hepatic carcinoma, abscess, or cirrhosis. And then bilirubin, which is the breakdown of hemoglobin, and is converted into bile products, and it rises in the presence of red blood cell destruction, malfunction of liver cells, and blockage of the ducts leading from the cells. Liver evaluation with ultrasound. So generally we look at the size of the liver. There are measurements that can be done from the diaphragm to the tip of the liver. We look at the attenuation of liver parenchyma, liver texture, and the presence of hepatic vascular structures, ligaments, and fissures. Our normal protocol for liver Doppler. So we follow through with our right upper quadrant protocol, the pancreas, liver, gallbladder, and right kidney, with the addition of our Dopplers. And then, I don't know if everyone's learned this, one thing I learned back in school with abdominal Doppler is you do not invert your spectral or your color Doppler. You should always keep it true. So when evaluating the liver, we rule out any regenerating nodules, masses, irregularities in the hepatic echo texture, and we look for an irregular liver surface. Once you get to the Dopplers, start by looking at the main portal vein, the right anterior portal vein, and then the right posterior portal vein, which the right posterior portal vein should be going in a direction away from you in a normal liver Doppler. Of course, if things have changed, that can be different. We also look at the left portal vein, the hepatic artery, and then each of the hepatic veins. We look at the splenic vein with a Doppler. On the image for this one, the splenic vein is actually going in a direction away from us. And the reason is it was taken in the left upper quadrant. You can see the spleen in the image. But like I said, you don't invert the color of the spectral flow, so that's still normal direction.
Oh, I see they did a color for egress and then, okay.
Yep. Yeah, and that was all in the same patient. There were images by the pancreas with color, but they took their Doppler by the liver, or I'm sorry, by the spleen.
Does it matter? No.
Shouldn't it?
What matters is you look at we know the direction and we can assess that from it. That's really the key thing. So velocities in the spleen, in the splenic vein, nobody really cares about. It's more the color flow and direction. And size of the splenic vein doesn't matter. I've noticed that a lot of people have been measuring splenic veins.
It's in our protocol.
That's part of the protocol that we have.
I don't know where this urban legend comes from.
Dr.
Dr.
Isaacs.
Isaacs.
No. You don't have to measure splenic veins, okay?
Okay, so scratch that. One indicator for portal hypertension is a measurement on the portal vein. If it's measuring greater than 13 millimeters, it can be an indication.
Yeah, we were always taught to measure the portal vein.
Yeah, and the measurement that we were taught was at where it crosses over the IVC. Here, we were
Your
taught
portal
splenic. For the portal vein, yeah. So we also do measurements on the spleen and then check for ascites.
Jess, what did you say about measuring the portal vein? Is that on?
No,
Or we're supposed to measure the portal vein?
no, but that's one place you can do it. It can indicate portal hypertension.
Oh, okay. I was writing something else when you were saying.
Nope.
And 13 is the number. Because I think one of the textbooks says
Yep.
10.
13 for
Like 13
Portal.
days for portal vein hypertension.
your what?
Your AP diameter?
For the
portal
portal
vein.
vein?
Mm-hmm.
It doesn't matter. I don't care what they say, it doesn't matter. So don't measure the portal vein. Whether it's big or small, it doesn't make any difference. The velocity is going to be more important because it's there along with the waveform as well as the direction of flow. So, yeah, size in the, so remember, veins are a capacitance system, right? So that means they're there to expand and contract relationship to volume or to other stressor states that are going in there. So, you could have somebody that's dehydrated in the morning, and their portal vein's 6 millimeters, and they get them tanked up and you bring them back in the afternoon and it's 20. Both are normal, and that's why direction of flow and velocities are going to be more important when we see this kind of stuff. And that's what I can tell you that I never heard of measuring these vessels when I got here. And from the interventional side, who has to deal with some of this stuff, we don't really care, So, yeah, let's make your life easier.
So for the hepatic artery, it should be all forward flow, low resistance. Typical systolic velocity can run from approximately 30 to 60 centimeters per second. Diastolic velocity 10 to 20 or similar to that of the portal vein.
I want to ask one question about that. More recently, younger people, hepatic artery, having systolic way above 60. Is that, yeah, like 120,
They can be the problem with doing hepatic arterial circulation is diet can influence that. You have to be really persnickety about doing all that kind of stuff. What we're going to be looking for there is, the one thing is the pulsatility index or the RI is often more important in these. And so you want to be thinking about, what's the resistive indices of what's going on in this situation, and what else are we seeing? Now, stenoses in the hepatic artery are not all that important unless you have a transplant. So that's where you come into play. Now, could we see something, or we do something about it in a transplant? Yes, and everybody else, it's going to be probably no. Okay. So that's why we don't get crazy. But if you see something that doesn't look right, you've got A-listing, yeah, you can come back and prove it.
So, for the hepatic artery then, for the velocity, are we supposed to be watching it? Because like she said, I did watch it once and I said something to her and they said, oh no, that's normal, when I thought it was really high, but I think it was on a younger person then. So I
Yes, it's more going to be more, get the velocity in there. So if you see a high velocity, what you should look there and say is, am I seeing a culprit lesion that's causing this to come out? So do I have a stenosis in line that's causing this velocity to be high? If you don't see that in the line and you have a normal spectral pattern, so you have a normal triphasic pattern, maybe it's a hyperdynamic state. you know, somebody that's in, there's something else that they're in overdrive or something else like that. Maybe it's something related to what some bizarre with fasting or non-fasting state and that, and that's why we tend to not get as hyped up about it. But if you see something that's high and you see a zone of aliasing, yeah, then that's a different thing. And you can sample and you can say, well, hey, I sampled here and it was 170 centimeters and I sampled, you know, 3 centimeters away from it, like you would do for a leg. Remember when you guys were training about that and how we always look about proximal distal lesions and what's the velocity elevation. So if we saw a doubling of velocity at that site compared to the inflow, then we might say, oh, there's a greater than 50% stenosis that's likely at this thing. But in the long run, unless it's a transplant artery, nobody's really going to do anything about it. Now, if we were doing celiacs for mesenteric ischemia, that's a different story. But for most of the stuff, we're not.
The portal vein should also be antegrade. Typical velocity approximately 18 centimeters per second plus or minus 5 centimeters per second. And then the portal vein is also the only vein that should be described with a portal hepatopedal or hepatofugal flow.
Can everybody keep that straight? You think your referrers can keep that straight? I would say to you, no. So if we want to put on there, the other thing is, if there's any question, always just write flow is towards the liver. Everybody can understand that, and it's not that I don't think you guys know what you're talking about, but that if somebody else would pick it up, they would say, was that fuel or pedal? I can't remember that. It's kind of like antegrade. Yes, hepatopedal flow is antegrade. But they're like, what is this antegrade? Which direction is flow? You know, and that's why I always just say, it's like we don't say superficial femoral vein anymore. You know why that is? Because people think it's a superficial femoral vein when it's a deep vein, and so that's why we don't say it. So I would just say, if you're going to put that in the charter, if we want to do something to say flow towards the liver.
I have a mnemonic if it's backwards. If anyone wants to know, you can ask me. Right?
Can't repeat it that
No, it's not.
Fungal?
Why does it
That's what you
head
learned?
forward?
Like,
Hepatofugal is fucked up flow.
we need to beep that on
That's
the
not you.
presentation.
Do you want me to stop?
Sorry.
I forgot we were talking.
So as for the hepatic vein, it can have antegrade and retrograde flow, and it's just due to the variations with cardiac activity. So portal hypertension is an increase in the portal venous pressure due to acute or chronic hepatocellular disease, thrombus, or tumor invasion causing the backup of blood flow. And then with that backup of blood flow, it can cause collateral circulation. These are just some of the more common vessels, and there's a diagram with them. But the gastric veins, esophageal veins, recannulized umbilical vein, splenorenal, gastrorenal, retroperitoneal, hemorrhoidal, and intestinal veins. A way to correct that is with the transjugular intrahepatic portal cable shunt, so with the tips. And what that is, a portal systemic shunt created to decompress the portal venous system. The shunt is placed between the hepatic vein and the portal vein, and it's effective at reducing ascites, preventing hemorrhage from gastroesophageal varices, and improves the quality of life in patients with severe cirrhosis.
Can I ask a question? I'm sorry.
Yeah.
So when you have a recanalized periumbilical vein,
Mhm.
what is the left portal doing? Because I hardly ever see it.
The left portal's still coming.
Because I don't know if it just
With the
is that-
tips?
No, the
No.
recanalized periumbilical vein. So whenever I try and find it, I can never find it.
It should be extending off of it.
I
The
just like, I
periumbilical.
don't even know.
And remember, not everybody's veins look,
Yeah.
there's all these variations on how they insert when they even come in utero. What you want to do is see, A, if you got a collateral, and B, is what is the direction of flow in that collateral in relationship to the portal vein. So if you can trace it and you can get it to the portal vein, So ideally, it'll have a reversal of flow of what you would have expected.
That's what I was kind of thinking, because it should be,
You
have to go
have-
backwards.
This is one of those issues where everybody, you probably all need to just sit down and draw the circulation knot yourself, and then just sort of see it, and so we can talk about plugging it and go through that, but, and because that's what I do in my brain when you show me stuff like this, because that's why we look at colors all the time, and look at flow direction, and where it is in relationship to the velocity, as Jess was saying, or indicate that you don't switch direction, because not all the machines show the inversion size, or that correction real easy.
So, and then even though tips are, it is a way of correcting the portal hypertension, they are subject to stenosis or occlusion. So different indications for tips, uncontrollable variceal hemorrhage that is not amendable to endoscopic therapy, prophylaxis against recurrent variceal bleed in a high-risk patient, portal hypertension gastropathy, refractory ascites, Budd-Chiari syndrome, hepatopulmonary syndrome, hepatorenal syndrome, and decompression of the portal systemic collaterals prior to abdominal surgery. Contraindications, elevated right and left heart pressures, heart failure and cardiac valvular insufficiency, rapidly progressing liver failure, clinically significant hepatic encephalopathy, uncontrolled systemic infection and sepsis, unrelieved biliary obstruction, extensive primary or metastatic hepatic malignancy, severe uncorrectable coagulopathy, and marked pulmonary hypertension. Polycystic liver disease is also one that's been on the contraindication list, although there are cases that they have done that they have placed a tip successfully for those patients as well. So this is just a diagram going through the procedure of the tips placement. Right here is just showing the tips coming from the portal confluence. The most common location for them to go is between the portal confluence and the right hepatic vein, although it can go in other ways if depending on the patient condition or what they have all going on with them. So then image B in the top middle is it's a right hepatic venogram, and it shows the course of the hepatic vein to prove that they're actually in it when they're doing the procedure. C is a balloon occlusion transhepatic portogram using carbon dioxide to show the course of the portal veins so that they can try and eye up the connection